Okay, I want to welcome everybody to the webinar on STI screening in the office setting. This webinar was developed by the members of the Adolescent Committee of Ohio AP for clinicians who see patients in an office-based setting. I'm Dr. Paula Braverman, and I'm an adolescent medicine physician at Cincinnati Children's Hospital and co-chair of the Adolescent Committee with Dr. Jim Fitzgibbon from Akron. And our presenters today will be Dr. Mariah Mirandar, who's a fellow in adolescent medicine in Cincinnati Children's, and Dr. Shireen Patterson-Rose, who's also a faculty member in the division here at Cincinnati Children's. We have supplemental slides that will be posted with more information when this webinar is posted on the AAP website, and we will take questions at the end of the presentation. You can also type in your questions as you're going, and we're presenting the webinar to you. So I'm going to turn this over now to our presenters, who will start.
Good day. I'm Dr. Patterson-Rose, as Dr. Braverman mentioned, and just to remind you, just to clarify, the target audience are clinicians who see adolescent patients. Our learning objectives today are to explain and understand the importance of confidentiality when caring for adolescents, understand the 5 Ps of taking a sexual history, to name the current preferred screening test for STIs, and to describe the recommendations for HIV screening. This is a list of the topics that will be covered over the next 45 minutes. I will be presenting the first 3, epidemiology of STIs in adolescents in Ohio, confidentiality, and the sexual history interview, and Dr. Ramandar will be covering the latter 3, STI screening and treatment recommendations, as well as how to prioritize screening. To start off, are teens in Ohio really at risk for STIs? Well, according to the 2013 Ohio YRBS data, overall, a little less than half of adolescents have had sex. Females are more likely to report past sexual activity than males. Also, the percentage of students who report prior sexual activity increases by grade, with 12th graders reporting the highest at 57%. Continuing with the same data set, looking at those students who have had sex in the past 3 months. In 2013, almost a third have had sex with one or more partners in the past 3 months. This percentage has had little variability over the past 5 years, but overall remains at about 30% or higher. Again, similar to the last slide, females are more likely to report one or more sexual partners over the last 3 months. The percentages also increase with grade level, with almost half of 12th graders having one or more partners in the past 3 months. So far, we've learned that adolescents are having sex and they may have one or more partners. This graph shows the percentage who used a condom during their last sexual encounter. You may look at this as the glass is half empty or the glass is half full. However, only 50% of high school students reported using a condom with their last sexual encounter. This means the other 50% are engaging in high-risk behavior that could put them at risk for STIs. Again, consistent with previous data, 12th graders are the least likely to use condoms at about 42%. So yes, adolescents do engage in high-risk sexual behavior, but how prevalent are STIs in this age group? This is the latest data from the Ohio Department of Health. In 2012, adolescents and young adults 15 to 24 made up about 14% of the total population of Ohio. However, in that year, they accounted for 3/4 of the chlamydia infections and 2/3 of the gonorrhea infections in the state. This disparity is even larger for females and most striking among black females. Among 15 to 24-year-olds, white females accounted for 5% of the total population, but almost 20% of the chlamydia infections. Black females accounted for 1% of the total population, but accounted for 21% of the chlamydia infections. This figure shows the breakdown of infections by counties. The counties that include the major cities do tend to have the highest rate of infections. However, the diseases are seen in all counties for chlamydia and almost every county for gonorrhea. Looking at where the disease is most prevalent, in 15 to 24-year-olds for chlamydia, 44% were from the counties that include Cleveland, Columbus, and Cincinnati in 2012. For gonorrhea, 54% were from the counties that include Cleveland, Columbus, and Cincinnati in 2012. Trichomonas is not a reportable disease for the Department of Health. However, based on prevalence studies, Trichomonas is the most prevalent non-viral sexually transmitted disease in the United States. Excuse me. In a teen clinic in Cincinnati in 2014, more than 10% of adolescent females tested for Trichomonas were found to be positive. This is in comparison to a positivity rate of 15% for chlamydia and 4% for gonorrhea. This emphasizes that Trichomonas is an important disease to consider when screening adolescents for STIs, especially those with high-risk behavior. This data now looks at the rate of primary and secondary syphilis, and this is from 2014. Again, similar to gonorrhea and chlamydia, the highest rate of infections are in counties that the major cities are in. However, there are still significant rates in many other counties. Please note that this figure is data for all age ranges and not just adolescents. However, it does emphasize that syphilis is present in the state of Ohio. This is another view of the data for primary and secondary syphilis, looking at it from the city level. Cincinnati is leading the way with the highest rates of syphilis in Ohio. The good news for Cincinnati is that the rates are declining. This is not the same for Akron, Canton, Columbus, and Dayton, where rates of primary and secondary syphilis are still on the rise. Again, the figure is for the general population. However, we do know the breakdown for the rates of infection across the entire state for 15 to 19 and 20 to 24-year-olds. Rates for 15 to 29-year-olds were highest in 2010 at 8.4, but has been declining since and was 3.3 in 2014, which is the latest data that's present. Rates for 20 to 24-year-olds have been up and down over the last 5 years. However, rates were 17.2 in 2010 and were down to 15.9 in 2014. This figure shows the history of HIV and AIDS in Ohio since 1981. As you can see, the number of persons living with HIV, the light blue bars, and persons living with AIDS, the dark blue bars, have trended upwards over the past 3 decades. The number of AIDS diagnoses, the maroon line, HIV diagnosis, the dark blue line, and deaths from HIV and AIDS, the gold line, peaked in the 90s and have been trending down since. However, these numbers remain significant, as in 2010, over 900 persons were newly diagnosed with HIV and over 500 with AIDS. This figure looks at the rates of initial diagnosis of HIV by age. The dark red line shows the percentage of infection among 15 to 24-year-olds. Over the 4 years of data, adolescents and young adults made up about a quarter of the new HIV infections, only secondary in some years to the 25 to 34 age group. Why are teens still susceptible to STIs? The answer is a multitude of reasons. Biologically, teenagers have exposed extropion or transitions between the columnar and squamous epithelium on the exocervix. The extropion is a normal developmental finding of the adolescent cervix in which the squamo-columnar junction is on the exocervix. This usually regresses into the cervical canal with advancing gynecological age. This transition area, however, makes adolescents more susceptible to STIs. Another biological reason is that teenagers have not been exposed to certain infections yet, antibodies. Lastly, teens may rush into sex without sufficient foreplay to produce lubrication, which can result in more traumatic intercourse and increased risk of contracting STIs. Behaviorally, young teens may have intercourse with older individuals who have had more years of sexual experience, hence an increased exposure to STIs. Many youth also engage in substance use or have mental health issues that may increase risky sexual practices and STI exposure. Cognitively, the frontal lobe of adolescence is still maturing, so teens are more likely to take risks and not think about consequences. They are more impulsive and believe they are invincible. And lastly, socially. Unfortunately, many schools fall short of comprehensive sex education or comprehensive health education, so teenagers may not have the basic knowledge about STIs, including prevention. Teens may lack health insurance or funds to pay for health care. Navigating transportation system can be difficult and a barrier for teenagers trying to seek care. Teens may also question confidentiality and be nervous to seek care for sensitive conditions. And lastly, teens may be fearful of the stigma attached to seeking care in an STI clinic or being diagnosed with an STI, so may avoid accessing health care for those reasons. Now for a case. Mary is a 17-year-old female who presents to clinic today for a sports physical. She was last seen about a year ago to be cleared for soccer. You've known the family for years and the patient has never been in any trouble. Should you speak with the patient alone? You should definitely speak to the patient alone. All states allow teens to consent to STI services. Ohio state law specifically allowed for minors to consent to STI services, including HIV testing. Minors cannot, however, consent to HIV or AIDS treatment. Many experts have also written statements supporting confidential care, including the American Academy of Pediatrics, the Society for Adolescent Health and Medicine, the American Academy of Family Physicians, the American College of Gynecology, and the American Medical Association. Lastly, confidential care is evidence-based. In a study published by JAMA in 2002, it showed that if parent notification was mandatory in regards to contraceptive services, more than half of teens would stop using all health services. 11% will delay accessing STI services, and only 1% would stop having sex. This study made it clear that parents, even if you only notified parents for contraceptive services, it would still affect STI screening and care. One thing to remember is that confidentiality does not extend to insurance. When providing confidential care, it is best to standardize the process. Some items to include are sending out the office's confidentiality process. This can be done at all new visits or for all patients once they turn 12 years old. It is important to discuss confidentiality process with adolescents and their parents in person. This can be done at their annual visits. While you may try to maintain confidentiality, it's not always possible. You should mention limits to confidentiality, including safety and/or abuse, as well as possible billing compromises. To ensure confidential response when talking to your patients, ask the parents to step out of the room before asking personal questions. To ensure that parents continue to feel included in the care, promise to invite them back at the end of the visit to review concerns. If the parent does not want to leave the room, then still conduct the confidential interview, and if appropriate, knowing that answers may not be completely truthful. Lastly, remind adolescents frequently about the confidentiality policy. There are multiple resources for confidentiality letters that you can adapt to your clinic's need. The AAP section of Adolescent Health has a toolkit that is customizable. If you are not a member of the section, the National Association of Pediatric and Adolescent Gynecology also has samples that you can use. Other examples are included in your supplemented slides, which can be found at the end of the presentation. This is an example of a confidential policy that can be placed throughout the clinic, or policy on confidentiality. Our discussions with you are private. We hope that you feel free to talk openly with us about yourself and your health. Information is not shared with other people unless we are concerned that someone is in danger. And this was an example from URMC Department of Pediatrics. To maintain confidentiality once the patient leaves the office, you should also obtain contact information where you can reach the patient. Try to establish a place in the chart or EMR where confidential contact information can be documented. Make sure to confirm and update this at each visit or as needed, as information may change frequently. Discuss with the patient what is the best way to contact them. Most adolescents have cell phones now, which may make the process easier. However, even with using a cell phone, it is better to contact by calling or by texting. And if not using a cell phone, is it better to call home, send an email, or send a letter through the mail? If sending a letter, whether through the mail or email, considers ways to try to maintain confidentiality, such as an agreed-upon symbol that signifies calling the clinic. If a contact source is given that is not directly the patient, such as a home phone or sibling's phone, then rules should be established for contact. A discussion should be held on what can and cannot be discussed with a third party and what to do if a parent becomes suspicious. Lastly, as a clinic, you should decide if patients will be called with all lab results or only with abnormal labs, and also decide if there will be an option where the patients themselves will call for results. One of the areas where it is very difficult to maintain confidentiality is during the billing process and with explanation of benefits. If a patient plans on using their insurance, the possibility of breaching confidentiality should be discussed. If this is a major concern for the patient, then alternate methods to obtain services can be reviewed. If the patient prefers to continue with the clinic, then paying out of pocket is one option to maintain confidentiality. A clinic may be able to set up reduced rate options to make this more feasible for adolescents. Another option would be to refer out to a Title X clinic, such as the local health department, family planning, or school-based clinic, where confidentiality can be assured. So continuing the case. After reviewing the sports pre-participation questionnaire, you plan to complete a detailed social history. How do you obtain the sexual history? There are many ways to obtain a sexual history. The most important thing is to have a systemic approach so all areas are addressed. One such approach is the use of the 5 Ps. Partner. Identify the gender of partners, male, female, or both. Determine the number of partners in the past 3 months and the number of partners since initiation of sexual activity. Practices. What are their sexual practices? Is it receptive versus insertive? Is it oral, vaginal, or anal? Please adjust verbiage depending on the maturity of your patient. At times you may need to be more descriptive, such as penis into vagina, penis into mouth, etc. Prevention from STIs. Are you using a condom? If you are, how consistently are you using it? Are you using condoms with all your partners or only a selected few? One question you can use is, on a scale from 0 to 100, what percentage of the time do you use condoms? Past STIs. Is there a history of an STI? And lastly, pregnancy prevention. What has been done or used to prevent pregnancy? And don't forget to ask the males this questions also about how their partners are being protected from pregnancy. When obtaining a sexual history, it is important to remind the patient about your confidentiality rules. It is also important to normalize the questions. One phrase you can use, this may seem a little different, but I ask all my teen patients these questions. So to summarize what we've learned so far, many adolescents participate in behaviors that place them at risk for STIs. STIs are also very common among adolescents in our state. As STIs may have serious consequences and may be asymptomatic, it is very important that sexually active adolescents are routinely screened. Now I'm going to turn it over to Dr. Ramandar.
Hi, everybody. Now that we know our teens are at risk for contracting STIs, we will discuss who to screen, how often to screen, and what tests to use. This summary chart is available in the supplemental slides. As the top row suggests, all sexually active females younger than age 25 should be screened for chlamydia and gonorrhea annually. All adolescents and adults between ages of 13 and 64 should be routinely screened for HIV at least once. You should consider rescreening high-risk individuals. We will discuss what constitutes high risk in a few slides. High-risk females should be screened for trichomonas and syphilis. You should also consider screening for syphilis in high-prevalence regions like Cincinnati or Columbus. There are no routine screening recommendations for all males outside of the HIV recommendations, unless the males are men who have sex with men, or MSM, or are otherwise high risk. MSM and other high-risk males should be screened for chlamydia and gonorrhea as well as syphilis annually. MSM with multiple or anonymous partners should be screened more frequently, up to every 3 to 6 months. Multiple partners meaning more than one. This slide is the text version of the screening recommendations that we just reviewed. As we will now discuss special populations and high-risk definitions in more detail. As mentioned on the summary chart, for MSM, chlamydia and gonorrhea screening specimens should include urine for all MSM, rectal swabs for those engaging in receptive anal intercourse, and/or pharyngeal swabs for those engaging in receptive oral intercourse. Another special population to not ignore for screening is women who have sex with women. Some women may have male partners in addition to female partners. Even in females who only have female partners, STIs can still be transmitted between females via sex toys or oral sex in the case of HSV, syphilis, or HPV infections. The definition of high risk is different based on the specific STI. However, most commonly, teens in your office should be considered high risk and screened more frequently if they have new or multiple partners, past STIs, or inconsistent condom use. From epidemiologic studies, other notable high-risk populations are those being seen in school-based high school clinics and those requesting STI screening. It should also be noted, with the rise in opiate and heroin use, IV drug users are also considered high risk for some STIs. While meeting with the patient alone, she reveals that she has had sex with 3 male partners, uses condoms inconsistently, and although she has no STI symptoms, she does agree to screening. She also isn't concerned about her parents seeing the bill, since they would want her to be safe and healthy. First of all, does the patient need a pelvic exam for STI screening? The answer is no. A pelvic exam is only required if the patient has symptoms such as abdominal pain, vaginal discharge, or dysuria, in which case you would be testing and evaluating for complications like pelvic inflammatory disease or other causes of discharge or dysuria, not simply performing asymptomatic screening. To screen for chlamydia and gonorrhea, nucleic acid amplification testing, or NAT, is the preferred method for genitourinary sites. NATs are more sensitive than previous screening methods like culture or DFA, and their specificity is equal to or better than the older methods. Comparison charts of various screening methods and specimens can be found in your supplemental slides. First catch urine, not a clean catch specimen, is preferred in males. First catch urine involves the patient providing the first 20 to 50 mLs of urine after the individual has not urinated for up to 1 to 2 hours. However, though first catch is ideal, if it cannot be obtained, do not let that stop you from screening. A positive result is a true positive, but a negative result is not necessarily negative if the specimen was not a first catch urine. In females, though vaginal or cervical swabs are preferred, first catch urine is also acceptable. However, you can miss up to 15% of chlamydia and gonorrhea infections if urine is obtained in females. If vaginal swabs are available, samples can be obtained through patient self-swab. Again, NAT should be obtained annually or more frequently depending on risk factors in sexually active females, MSM, and high-risk males. Although there is not FDA approval for pharyngeal or rectal swabs using NATs, some labs have completed the required in-house validation studies and may offer this option, which will be more sensitive than culture. Check with your lab that you use to see if NATs are available for these other sites. Moving on to trichomonas. There is a relatively new rapid test that can be done in your office. Its sensitivity is superior to wet mounts, meaning more cases of trichomonas are identified with the rapid test, and no in-office microscope is necessary. Testing comparison charts are available in your supplementary slide set. Vaginal swab samples should be obtained from high-risk females, and self-swabs can be used. Results can return in 10 minutes, which allows providers to treat in the office during the visit. Test costs about $5 to $20, and the CPT code is listed on the slide. Back to the case. You recommend that Mary be screened for chlamydia, gonorrhea, trichomonas, syphilis, and HIV. She consents to providing vaginal or urine samples, but is not mentally prepared for a blood draw today. What alternatives can you offer her for syphilis and HIV screening? For syphilis screening utilizing a blood draw, the traditional testing you may remember from medical school is being replaced by testing that reverses the algorithm, starting with the treponemal-specific test like a TPPA or FTA antibodies. Then, if positive, it is followed by a non-treponemal test, such as an RPR or VDRL. The emerging testing algorithm can be found in the supplementary slides. Reversing the algorithm allows for less false positive on initial screening, which can occur on the non-treponemal tests with pregnancy, mono, or lupus. Similar to trichomonas screening, there is a relatively new rapid syphilis test. Samples are obtained via fingerstick. Results return in 10 to 15 minutes. Test supplies cost around $8, and the CPT code is listed on the slide. You can trust a negative result, but positive should be confirmed with a send-out test from a venous stick. As a reminder for HIV screening, the CDC recommends that teens and adults should be screened at least once and rescreened if risk factors are present. Pretest counseling or separate HIV consent forms are no longer recommended. Your office should determine how positive results will be delivered, and it is helpful to know about the referral resources for adolescents who are HIV positive in your area. Rapid HIV screens can also be done in the office and have an excellent sensitivity and specificity, similar to conventional serum tests. Rapid tests require a fingerstick or buccal swab for oral fluid. Results return in 5 to 40 minutes, depending on the test. Tests cost around $20, and the CPT code is listed on the slide. Like with the rapid syphilis screen, you can trust a negative result, but positive should be confirmed with conventional testing from a venous stick. An up-to-date list of approved HIV tests can be found on the FDA website. So, Mary provides samples for screening, and the rapid trichomonas result is positive. What are your next steps? One-time treatment is the preferred method for treatment for several STIs and can be provided in the office. Trichomonas can be treated with 2 grams of metronidazole or tinidazole, and you should remind the patient to avoid alcohol for 1 to 3 days following treatment. A complete and up-to-date list of STI treatment guidelines, including alternative regimens in the case of allergies, can be found on the CDC website and in your supplementary materials. Back to Mary. 2 days later, the lab informs you of her positive chlamydia test. Your nurse attempts to notify the patient using a confidential number listed in the chart. What should the nurse do if a parent answers? The nurse should ask for the patient, and if she is not available, ask to have the patient call the office. If the parents request to know the reason for the call, the nurse can reply that she or he is unable to release the information. And if further pressed, politely remind the parents of the confidentiality policy and state that the information cannot be disclosed without the patient's consent. Clearly, the goal in obtaining a confidential number is to avoid this type of awkward exchange, and you would want to discuss the risks of disclosure to the parent if the only contact method provided involves the parents. When the patient is contacted, you will need to arrange treatment. One option is to schedule an office visit, which does not have to be with a physician but could be with a nurse. See the EM code listed on the slide. In order to provide in-office treatment, you will need to stock azithromycin, ceftriaxone, and metronidazole. Alternatively, you could send a prescription for oral medications to the pharmacy, but be sure to discuss possible breaks in confidentiality, such as the pharmacist notifying the parents of a prescription that's ready for pickup. While you have the patient's attention, it would be a great time to schedule an appointment in 3 months to screen for reinfection. The risk of reinfection is much higher than treatment failure, so the point of this visit is to see if the patient has been reinfected by partners who did not get treated or by a new partner. While arranging treatment for the patient, you also want to discuss notifying partners so they can be treated. Physicians are not required to notify partners, but can help guide the patient through this process. It is not uncommon for a teen who is angry about getting an STI to say that they don't plan on contacting their partners and may need some guidance on the importance of their partner being treated, even if they don't intend to continue the relationship. It is important to know how your county health department handles positive results, specifically for HIV, since it is illegal in Ohio for a person to have sex with an individual without disclosing their HIV positivity. Recently, expedited partner treatment became legal in Ohio, so a prescription can be provided for partners, or you can offer to treat partners in your office. Since the law is relatively new, it is important to discuss with your local pharmacist to ensure that they are aware of the new legislation. Alternatively, you can provide information about other treatment locations, such as local Title X or health department clinic information. Don'tSpreadIt.com is an option for patients who feel uncomfortable or unsafe notifying partners personally. The website allows anonymous emails or text to be sent to partners and links to a treatment facility locator. Though we have discussed the importance of confidentiality, we know it has its limits, particularly when safety is a concern. On a rare occasion, medication side effects can occur, and this may be an instance where you would consider breaking confidentiality. In this case, you should remind the patient of the limits of confidentiality and discuss the information that is important to share with the parents, along with the information that can remain private. You may want to allow the patient to disclose to parents before you talk with them. Depending on the case, clinicians can decide whether conversations are best had during an office visit or over the phone. We have discussed why screening is important, and now we will review how to make screening a priority in your office. The first step would be to identify an STI screening champion who will lead the effort. It is important to train all office staff on screening protocols, including the front office staff, who will be obtaining confidential contact information. You also should create a way to flag patients who are due for screening, whether through an automated mechanism in your EMR or utilizing support staff to review charts prior to patients' appointments. We would also recommend normalizing private time and discussing sexual activity at each visit, not just during physicals. Also important is standardized documentation and updating of confidential contact information. Additionally, you should try to have screening materials, treatment medications, and condoms for prevention available in the office. Some screening materials include sterile urine cups, vaginal swabs for chlamydia and gonorrhea, point-of-care tests, and the ability to draw blood in your office. Consider creating a confidential bathroom where screening materials can be obtained and left without the patient having to walk through the public office spaces with swabs or urine cups. Lastly, attempt to maintain confidentiality on paperwork, using small handouts that can fit in a wallet, pocket, or purse, and making confidential diagnosis not visible on after-visit summaries. In conclusion, confidential STI screening can be done in your office. Laws support confidential screening in every state in the U.S., and experts agree that confidential STI care is important for teens, since teens are unlikely to seek care if confidentiality cannot be maintained. The 5 Ps will help you remember the key components of the sexual history. Urine or vaginal swabs are acceptable specimens for gnats to screen for chlamydia and gonorrhea, though vaginal is preferred. And finally, all adults and adolescents should be screened at least once for HIV. We would like to thank the following members of the Ohio chapter of the AAP Adolescent Committee for their assistance and feedback in preparing this webinar. And here are a couple slides of sources that you can review.